Okay, good day everyone. Today we are on our 28th session of Learning Basic Arthroscopy series of lectures. We have a very interesting and slightly um, what we can consider to be a more complex talk. We have Dr. Dipen Menon. Please let me share my screen. Okay, Dr. Dipen Menon has already delivered a lecture with us. Dr. Dipen Menon is consultant orthopedic surgeon at Kettering General Hospital, NHS Foundation Trust, affiliated to the University of Leicester in United Kingdom. Welcome, Dr. Dipen Menon. Thank you very much for agreeing to share your knowledge with respect to ACL Registry with us today.
Short introduction.
You have CV with you. Dr. Srinivas?
Yeah, I can short introduction to Mr. Menon.
Yeah.
Good evening, everyone. It's a pleasure for me to introduce Mr. Menon. He was my teachers when I was working in the UK. He did his masters from All India Institute of Medical Sciences, New Delhi, and higher surgical training in the UK. And he did fellowships in Chertsey, Oswestry, and Wrightington while in the UK. And he was appointed consultant at Kettering General Hospital in 2003. He's been working there as a consultant since. And his special interests include arthroscopic knee surgery, knee osteotomies, hip and knee arthroplasty, revision arthroplasty of hip and knee. A warm welcome, Mr. Menon. Thank you for accepting our invite. And thank you for accepting our invite, Dr. Skand Sinha. We welcome you. Over to you, Sasi.
And Dr. Skand Sinha has kindly accepted to be an expert panel for us today. And Dr. Skand Sinha is professor and senior specialist at Sports Injury Center, Sadarjung Hospital, New Delhi, from India. Thank you very much, sir. It's a pleasure having both of you here today. Yeah. Over to Dr. Dipen Menon. You can share your screen, sir.
Yes. So thank you very much for asking me to present some data on the registry. I'm going to look at this from various angles. And as I mentioned before, I'm Dipen Menon. I'm a consultant in trauma and orthopedics in Kettering Hospital. This is in the United Kingdom. So I hope that this will be of interest to people who are listening. I have no disclosures with respect to this presentation. Now, this is a brief outline of my talk. I'm going to, first of all, introduce you to registries, go into reasons why these were established and some of the advantages of having a registry. I will then go into some of the data available in the Scandinavian, US, UK, and New Zealand registries. And this is available on the various websites available to everybody. There are certain common themes which emerge from multi-registry data, and I'm going to look specifically at revision anterior cruciate ligament reconstruction and how the practicing surgeon can use this data to their advantage. Of course, with any data, there are limitations to interpreting it, and it's important to understand those limitations as well. So first of all, why have a registry? The lifetime experience of an individual surgeon is always limited. It takes a long time to build up an effective database of your own individual experience. And of course, one has to factor in confounding factors. And of course, there are variations in practice between different surgeons. And this largely depends on one's training. What is an ACL registry? So these are basically databases where patients are inputted once they undergo an ACL reconstruction, and this allows prospective surveillance, long-term follow-up, as well as survival analysis. So registries also provide continuous feedback to surgeons and units, and this can help improve practice. One of the very good uses of registries is that they serve as an early warning system. So implants and procedures that fail, particularly those that fail catastrophically, can be picked up very early because of the large data sets. So if you then go into the history of registries, you will see that the first registry that was established was a Norwegian registry in June 2004, followed by the very next year registries in the US, Sweden, and Denmark. Later on, registries were established in Luxembourg and in 2013 in UK and New Zealand. So the advantages, as mentioned before, this is basically observational data. As registries become more mature, you get very large data sets, and this data is introduced prospectively at staggered intervals at the time of each reconstructive procedure. The surgeon population that contributes to these registries is a representative population. It consists of most of the population of surgeons in that particular jurisdiction, and therefore that represents the average surgeon. And also, it is possible to identify and analyze subgroups and also find associations. Because of the very large data sets that we have, it is possible to some extent to factor in confounding factors with greater certainty. Now, everybody knows that ACL reconstruction is a very well-established procedure, but despite this being done for so many years, there are still so many controversies surrounding graft choice, tunnel drilling, and fixation methods. Now, this is some data from the Swedish registry. You can see that the incidence of ACL rupture in Sweden is about 32 to 80 per 100,000 inhabitants per year. About 1/3 to half of these patients undergo an anterior cruciate ligament reconstruction. The average age of patients who undergo ACL reconstruction is about 28 years. A little less than 50% are women. About 3/4 of surgeons in Sweden perform less than 30 primary ACLs per year, and about 40% less than 10. The ACL injuries, everybody knows, predisposes to radiological osteoarthritis, and about 50% of patients who have an ACL injury develop radiological osteoarthritis about 10 to 15 years post-injury, irrespective of what treatment they're given. Now, registries also record associated injuries. So this is recorded at the time of ACL reconstruction. This data is taken from UK and New Zealand, and associated knee injuries are found in the UK in about 54% of those undergoing an ACL reconstruction. In this subgroup, there are meniscal injuries, chondral injuries, and injuries to other ligaments which are less common. So the most common injuries are the meniscal and chondral, and the data in the UK has certainly, UK as well as New Zealand, have shown that the medial meniscus is more commonly injured compared to the lateral, and chondral injuries are more common on the medial side compared to the lateral. And in New Zealand, about 3/4 of the chondral injuries are not treated. About 30 to 40% of meniscal injuries are repaired, and particularly there's a greater preference to repair lateral meniscal injuries, which is important. Now, when I did my last talk on all inside ACL reconstruction, I was asked about extra-articular procedures. You will note from the UK registry data that this is not very commonly performed. So lateral tenodesis is performed in about 2% of patients who undergo an ACL reconstruction. An anterolateral ligament reconstruction, which is a relatively new procedure, is done in 2 in 1,000 patients. So that's not a very high figure. Now I'm looking at data from the Swedish registry here. You can see that most of these patients receive their surgery as day cases. About 20% of patients following an anterior cruciate ligament reconstruction require further surgery within the first few years, usually to address meniscal or cartilage problems, and about 1 in 20 may need a revision. So it's also well known that the scores following secondary surgery are poorer compared to primary surgery. Now, looking at some of the data from the primary ACL reconstruction, you will note that the hamstring remains the most popular graft in Sweden, Norway, Denmark, UK, and New Zealand. US also, it is the most common autograft that's used, but in the US, this data is from the Kaiser Permanente registry. Allografts were used more often right up to this time frame of 2013. Bone, tendon, bone about 24.7%, and hamstring is a much higher percentage. Now, there has been a change in trend with regard to autograft use in Norway, and this has been noted from 2013 to 2017. So in 2013, about nearly 70% of patients had a hamstring tendon ACL reconstruction, and about 30% patellar tendon. Now, over the past 5 years, that is from 2013 to 2017, the trend has reversed. So 65% of patients in Norway have a patellar tendon ACL reconstruction and about 35% hamstring tendon. And this paper from the American Journal of Sports Medicine, published in 2015, which gathered data from 2004, the time of establishment of the registry, to 2013, suggested that the hazard ratio for hamstring tendon revision was higher than patellar tendon. And this may account for the change in trend. So registries can change the surgeon's practice in a particular jurisdiction or a country. However, if you look at New Zealand data, you will still find that this data was taken from last year. You find that the vast majority, almost 75% of ACL reconstructions there are using hamstring autograft for their primary ACL reconstruction. If you look at graft fixation techniques next, which is data here from the New Zealand registry, the ACL tightrope remains the most popular fixation on the femoral side and the ABS button on the tibial side. And you can see that there is a progressive reduction in the use of screws in New Zealand. I'm looking now at certain patient outcome scores. This data is taken from the latest UK registry 2020, which appeared this year. You will note that the EQ5D index, the EQ5D VAS scores, the KOOS scores, as well as the Tegner scores all show an improvement following ACL reconstruction. So we are doing things right, I guess, from that perspective. Patients are noting improvements. This data is taken from the New Zealand registry, which shows the complications of ACL reconstruction. And you can see there are various complications recorded, which include intraoperative, postoperative, and also some patients with recurrent instability who need revision surgery. Now, I'm looking next at some recent trends. Now, if you look at the data from the Swedish registry, there has been a slight reduction in the use of hamstrings, and it's now currently at 89%. And there has been a progressive increase in quadriceps tendon use to 5% and patellar tendon 5%. Femoral fixation has changed from cortical buttons from 10 to 90%, and there's been an increased use of tight ropes to about 58%, and interference screw use is reduced. As far as tibial fixation is concerned, cortical button fixation has increased to 57%, and there is a gradual decline in the use of resorbable and metal screws. So it looks like cortical fixation is favored here in Sweden compared to other jurisdictions. If you look then at combined registry data from the Scandinavian registries as a whole, one of the things that stands out is that younger patients generally report better knee function following ACL reconstruction, but there is an increased risk of reoperation in this group. And females have a higher risk of contralateral ACL reconstruction. So they do well with the operated side, but then go on to rupture the opposite side and then require reconstruction on the opposite side. Patients with other injuries associated with ACL reconstruction, as would be expected, report poorer outcome scores. And patients with associated cartilage injuries have a lower risk of reoperation. If you look at surgical factors, again, this is data from the Scandinavian registries combined, and you will see that the most popular graft is the hamstring graft in Sweden as well as Denmark. But as I mentioned before, this trend has reversed in Norway. Hamstrings are noted to have a better short-term knee function, and also the risk of reoperation is slightly higher with hamstrings. if you look at the data from all three registries combined. And the risk of reoperation is reduced by about 14 to 17%. In the Scandinavian registries, it's 14% for every 0.5 millimeter increase in graft diameter. And in the US registry, it's about 17%. Now, here is some data comparing US and Scandinavian registries. I will particularly ask you to look at this revision data. You will note here that the revision rate is higher in the US registries compared to the Scandinavian registries, and there is a reason for this. This is because the US surgeons used allograft as their primary ACL graft until they found that this was not suitable. So this trend has now changed. And again, it shows how registry data can alter surgeons' practice. Now, I'm also now going to look next at multi-registry data, and this includes data from the US, the UK registries, New Zealand, as well as Scandinavian registries. And this consists of multiple patient factors, surgical factors, which include graft drilling techniques, as well as fixation. An interesting paper came out on this by Rahadja in the Knee Journal in March 2020, which showed that age is one of the most consistent factors which is associated with revision ACL surgery. This systematic review was basically looked at 10 studies from Sweden, 4 from Norway, and about 6 from Denmark, 10 from US, and 3 studies which were multi-registry data. Now, if you look at the factors that have been studied historically, which look at graft failure and revision, the factors that were looked at were patient and surgical, and you can see multiple factors there like age, PROMs, sex, BMI, ethnicity, concomitant injury, etc. And likewise, on the surgical side, there are multiple factors that have been looked at, like the graft type that was used, allograft versus autograft, graft processing, drilling methods, graft fixation, graft diameter, single versus double bundle. All these have been looked at in various registries. So if you look at I'm going to look at data in order. The one set of which the evidence quality is the highest, I'm going to put first. So the one that is the highest quality evidence available from registry data is the effect of age on revision. If you look at a person who's less than 21 years of age, who undergoes ACL reconstruction, and compare that group with somebody over the age of 40, the risk of revision surgery is about 8 times higher. So that is a very high figure. So the hazard ratio there is about 7.76. If you look at other age groups, 21 to 30, the hazard risk is slightly lower than below 21. And 31 to 40, it gets a bit lower. So there is a trend there. As you grow older and you receive an ACL reconstruction at an older age, the revision risk reduces. So with every 5-year increment in your age, the revision risk reduces. And therefore, because of this trend, the evidence quality is very high, and all the registries agree with this data. It's in agreement with all registries. So again, this evidence is of high quality. If you look at outcome scores, the knee injury osteoarthritis outcome score, which is less than 44, is associated with an increased revision rate, whereas those with a score above 44 have a lower revision rate. And here again, the evidence quality is not high, it is moderate. And this is because not all registries agree on this. If you look at graft, effect of graft, hamstring tendon has got a slightly higher failure rate than patellar tendon. And if on the right-hand side table, you can see the hazard ratios. And you will find here that because the Swedish registry does not agree with these findings, the evidence quality is moderate. And remember that these registries contain very high volume of data. You're talking about something like 40, 50,000 patients. So if one registry doesn't agree, then that takes away a lot, and the evidence therefore becomes moderate rather than high. Now, this data has been taken from the New Zealand registry. You will see here that this is a survival analysis, and you can see that the blue line is the patellar tendon, which has a lower revision rate compared to the hamstring tendon. And this has now prompted the New Zealand registry to commence a randomized controlled trial to find out whether this is actually true. Now, the next thing that I would look at is allograft versus autograft. The maximum data that comes out of the American registries, Kaiser Permanente, because they were the people who were using this data. I mean, this graft, sorry. The allografts are found to require 3 to 5 times higher chance of failure and revision, therefore. Evidence quality here is moderate. If you look at allograft processing, irradiated grafts, particularly those that receive radiation more than 1.8 megarads, are associated with a higher risk of revision. Again, the evidence quality here is moderate. If you look now at femoral drilling method, femoral tunnel drilling method, this is interesting because there has been a recent trend for anteromedial portal drilling, but it has been noted that transtibial drilling is associated with a lower revision risk, which I found a bit surprising myself. And you can see the hazard ratios on the right-hand side. The evidence quality here, again, is moderate and of course needs further studies. The New Zealand registry has clearly found that the anteromedial portal drilling is not associated with an increased revision risk, but the Swedish registry, as well as the one from Denmark, as well as US, don't agree with this finding. If you look at fixation methods, again, there is a slightly higher risk of revision if you have cortical fixation compared to aperture fixation. And on the right-hand side, you can see the hazard ratios. So as surgeons, how do we apply this data to our own routine practice? I don't think by reading registry data, you're going to completely change your practice, but it is important that you try and identify the population of patients you're treating. So are they mainly young professional athletes, or are they a combination of patients? And this is an important thing for an individual surgeon to understand. Secondly, is the technique that you're using suitable for all your patients? So it may be that you might have to modify some of your techniques to some extent for a patient who is young, maybe, and somebody with a high Tegner activity index above the level of 6. So you then need to decide whether you would use a completely different technique, or would you modify the technique that you use yourself. And of course, you then have to also look at your own skills, and are you adept with all techniques? And sometimes if you feel that a particular technique is not within your area of expertise, it may be possible then to refer on to somebody who's better at dealing with that group of patients. Of course, registry data has got limitations. The reason for that is that the data in different registries are standardized in different ways, and therefore it's difficult to compare registries. You can find trends in different registries, but comparing one registry with another is difficult. It is also difficult to extrapolate the results of different populations to your own population. And of course, some of the indices that are used, there are questions as to whether they're sensitive enough. For example, the knee injury osteoarthritis outcome score, the KOOS and the EQ5D, are not ACL specific instruments. And therefore, we need to probably look at finding more specific instruments which look at results following ACL reconstruction. So that is important. The other thing which is worrying is that the response rate, which usually once these patients are on the registry, they're sent questionnaires and they have to reply to these questionnaires. And the response rate tends to generally reduce with time. So at about 2 years, about 50% respond. At 5 years, about 40%. So that really takes away from the value of the data. Finally, the control group is not there in these registries. And now some registries like the UK as well as the New Zealand registry are planning to add conservatively treated patients to their registry so that you have a control group. And remember one thing, the data in registries only can be used to generate a hypothesis. And you need to then plan future studies to try and answer the question which you've generated from your study from the registry. Registry data does not prove causality, and that's what I mentioned in the previous statement. And of course, one of the other disadvantages of or limitations of a registry is that a revision operation may not provide a complete picture of ACL failure because a failed ACL may not be revised for various reasons. We all know that rehabilitation protocols may influence failure, and registries do not record this, although some registries are planning to do this, like New Zealand and UK. So to summarize and conclude, Registry data is prospective, contains large data sets and can identify trends. We have high quality evidence that younger patients require revision surgery. Other data like PROM scores, femoral drilling, fixation, graft type, etc., evidence quality is moderate. Certain registries like the KP registry have developed a risk calculator for revision. Outcome data, as you can very well see, can influence surgeons, and it has happened in Norway. It has happened in countries like the US as well. And remember that data is only one part of the puzzle, the data from registries. You then need cohort studies as well as randomized controlled trials to try and answer your question. Thank you for your attention.
Thank you very much, Mr. Dipen Menon. That was a discussion on a topic that is not usually touched upon, and that is usually considered as a confusing topic. Thank you very much for making that quite a easily understandable one for us. And we didn't get a lot of interesting and puzzling outcomes out of these registries. Some of them are quite established, like autographs doing better than allografts having a higher revision rate than autograph. But there are also other outcomes that were previously suggested by other studies, but not exactly confirmed. Like yes, young age groups definitely have higher revision rates in comparison to older people, but we also have slightly more confusing findings, like transtubule doing better than transfertile, possibly, as you suggested, as you rightly pointed out. We possibly need more and more actual comparative studies, but maybe with respect to transtubule versus transportal, which is I think a prospective study is almost sort of not feasible, because we have like completely moved over to transportal because of multiple theoretical benefits out of them. And it is to be very much, as you pointed out, very much to be understood that these data can be used for generating hypotheses, not exactly extrapolating the outcomes of these studies to other patient population. And thank you for also pointing out that it is not exactly possible to compare the data, but it's actually useful to check the trends of the data. When you check the trend in the data, you actually sort of control yourself in a previous time frame from a new time frame, rather than so a lot of other parameters possibly get neutralized, confounding parameters get neutralized. Whereas, as you pointed out, when you compare in between the data, in between two data, there are lots and lots of confounding parameters that could actually make an outcome which is possibly not right because of the confounding factors. Thank you very much. Can you please tell us more about, the very basics of registry data, like accessibility for the general population, for the younger people? So how accessible is the data? And if you want to suggest something for the younger researchers over there, could you give them some directives as to what sort of research works they can think about, if they have to think about?
So I think the thing is that the data is easily accessible. If you you are able to Google this, if you look at Swedish knee ligament registry or the Norwegian knee registry, you will be able to get data. Now, some of these, for example, Sweden produced its last annual report in 2018. So I've not seen anything from 2019. New Zealand has published one in 2019. UK has published one this year. Norway, I was finding it difficult to get papers after 2017. So, so the data is available, and I think more than that, I think there are also systematic reviews looking at data from multiple registries where they've looked at so these the data from various registries are used to publish papers. So they then go into various cohorts within a particular group within the registry, and then try and look a bit more closely as to the reasons for failure. And I think that kind of data is then used in systematic reviews to try and come up with some kind of hypotheses. And also, they can also increase the power of these studies, because you're picking up specific data and then doing RCTs on them. So that is one of the things. So you basically, the trends are the only thing that you can see from this kind of registry data. But if you contribute to a registry as a surgeon, you do get feedback. And certainly I contribute to the hip and knee registries, and every year I get feedback saying that, this is the number of cases I've done, this is the sort of failure rate, etc. All that comes to your own, it's like a confidential data which comes to you. So that sort of way is there. So talking about research, now there are different areas that people can look at. Obviously, drilling techniques and those kind of things, as you say, may not be that useful at this point in time, because people are moving away from transtibial drilling to transportal drilling. And but however, there are you may be able to try and look at why transportal drilling is associated with increased failure, and you might be able to look at what you think are the reasons for that. For example, it might be the angle at which the graft is going in, and the sort of force that is exerted at the edge between the tunnel and the graft. So there are things like that researchers have to sort of try to answer those questions. And when you get a proper question like that, then you have to do a trial in that particular area. And then it could be either a biomechanical kind of study where you can look at this thing, or you can then try and look at sort of radiological features that may suggest that there is some tension in a particular area in the graft, where it enters the socket or enters the tunnel. There are things like that. So you have to, first of all, frame a question based on the hypotheses and how you're going to answer that question. So RCTs are the way forward, but then RCTs require a lot of input. And I think you will need to get multiple centers involved in that, because unless you get a very high volume of patients, and unless they're randomized and it's multi-centered, then it doesn't sometimes provide very good data. So it's important to plan an RCT, and therefore it takes some time. In fact, nowadays you will find that when an RCT is planned, the plan itself is published so that people can look at flaws in that plan. And before you start the study itself, if you can pick up the flaws in that study, then you can address them before you start, because once you've gathered the data, it becomes too late to then change it. So there are various questions that stem from registry data. And I think when you read registries, you will ask yourself questions, and then you've got to then plan a research study based around that. So that's what I would advise the younger surgeons: read the data, and you will find, certain trends that you might be surprised about. And you then try and frame a question and then try and answer that. So that is the way forward.
I think things are getting more and more interesting. As you said, for example, we cannot actually compare between transportal and transtribute technique, but as you suggested, possibly there is something else that is also of issue in the transportal technique itself. And possibly when we are addressing that with some RCT or some biomechanical studies, we possibly can make the transportal technique better and better, rather than actually thinking of moving over to a transtribute technique, because possibly that's showing some sort of an improvement. And possibly the registry data can also serve as a pilot data for calculating the incidences of certain complications or of certain events when you are planning a RCT. Yes, those are very, very important and interesting points. Dr. Sinha, do you like to share some of your views with respect to this in general about ACL registry?
We have interdepartmental registry, but we don't have a national registry in India. So every department has its own database. We also have a database, and we look into our database. Depending on the aspects that we discussed today, the most popular choice for graft still remains the hamstring. We use quadriceps graft only in females and multi-ligaments and people who have laxity of joints.
Okay. So, can you, other findings that you could be able to share with respect to the data that you have? What is known so far, like with respect to the age, the revision rates?
We get mostly athletes, so the revision rate in athletes depends on what kind of sports they play. The people who are in contact sports, they get re-tears, mostly traumatic re-tears. And non-traumatic re-tears are very, very unusual. But primarily we use hamstrings and followed by peroneus longus, and rarely quadriceps in multi-ligament situations. And we find that graft in females, the hamstring grafts in females is not as good as you get in males. So in females, we use peroneus or quadriceps. In athletes, I'm talking about athletes.
Mr. Menon, now that Dr. Sinha pointed out regarding the causes of re-tears, do we have evidence with respect to the cause of re-tear in between, like a traumatic, biological, and technical errors?
So there are different, I mean, unless the surgeon or the database inputs that kind of data, you don't get that data. But there is, if you look at registry data, there's limited evidence on this. But having said that, traumatic re-tears are generally more common than, in the high-end athletes are more common than the tears which are due to non-traumatic causes. So that is certainly known. But having said that, registry data, I have not looked into the full details of why that happens. We don't even know, for example, tunnel site placement, those kind of things we do not know. Once you find a particular group, so if you find one group is doing better than the other, then the researchers from these registries, then they look at that particular group of patients and then they go further into detail, and that data only they will have. We will not be able to access that data. So at the moment, they will just say, for example, that a particular technique has got poorer results. But once they do that, the hypothesis is generated. Then they will look at that particular subset of patients and then study that a bit more closely. They might look at the x-rays of that patient. They may then look at the mechanism of injury, what caused the re-rupture, all those kind of things. And then they're able to come up with a paper on that. So this is how, I think from the Kaiser Permanente registry, about 70 publications have come out. And each of these are very high quality publications, which usually appear in American Journal of Sports Medicine and these big journals. And that's because they have such a huge database that then they can go down to individual cohorts within that and try and answer the question that is being asked. If they can't answer that question, then they probably then look at a RCT, setting up an RCT to see if that question can be answered. So it's all very laborious and painstaking. It takes a lot of time, many years to. So if you look at the data from registries over so many years, we've not been able to come up with high level evidence on very few things, actually, not many things. You would have expected many more.
I think, as you suggested, the more and more valuable data or information can be obtained when the actual surgeon from their own, from that particular region can call back the patients and try to answer the specific question raised by the data from the registry. That's again a very interesting point. Dr. Sinha, now that you have quite some experience with respect to maintaining registry within India in your department or institution. There's little maybe there is little efforts with respect to maintaining more pooled data or registry, or possibly we are lacking coordination with respect to maintaining data in India. Do you have some suggestions as to how we can go ahead with possibly improving the situation of data entry in India?
National registry has to be created, but there has to be an organization looking after the registry, because busy surgeons, they can't maintain registries. It is a office work, and it has to be coordinated effort. And India being such a big country with so many centers, the coordination is, I think, the part which is lacking.
Okay, Mr. Menon, you are already involved in a registry, in the UK registry, and you have experience with respect to contributing to it. Could you throw some light as to what aspects have to be improved on? Suppose suppose there is a motive to go ahead with a registry in India. So could you give us some guidelines as to what aspects are very important not to be missed and which could help us in future?
So, sorry, I think, yeah, so basically, I think with the UK registry, how it was established, you need some kind of a body which is separately administered. That is important. It doesn't necessarily need to be a government body, but yes, if it's a government body, then you get funding for it. That's the advantage. So that is the first step. Second step is that if, as surgeons on the registry, it becomes a part. We have an appraisal process. So every year you have to go through an appraisal, and your data has to be shared with your appraiser. So basically, it becomes, as you make it more compulsory, so then surgeons have to contribute to it. So for example, if you do a hip and knee replacement in the UK, you have to contribute your data to the registry, and there are hospital staff who will input the data. And of course, there are multiple things that we got to look at. What was the sort of, there are multiple sort of subheadings in that, which they will pick up from the operation notes, etc. And now we are making operation notes computerized, which will automatically input data. And that will be a thing of the future in a few years' time. As you put in your operation note and all the relevant data is entered in your operation note, those bits of the data are automatically fed to the registry. And the implants that you use, etc., that is also fed to the registry. So the registry collects all this data, after which, and you preoperatively, you got to record the patient's outcome measures, the PROMs. So the patient will have to actually fill in the SCOO score, for example, or in the, there are other scores for hip and knee replacement. So they'll fill in these scores, and that is also inputted in the registry. Now, once the patient is, discharged from hospital, they get some questionnaires to fill in at about, 6 months or a year, 2 years, 5 years, like that. And so that those questionnaires need to be returned back to the registry, and that data is again inputted. So from that, you're able to find out how processes or implants that you use for reconstructive surgery, like ACL reconstruction, how they perform, how individual surgeons are performing. So that can be sometimes an issue which some people find difficult to handle. That is that you're also under scrutiny yourself. So as a surgeon, if they find that all the ACLs that you're doing are all failing, then clearly either you got to stop doing the technique or retrain or do something different. So it is but it is important, because you're trying to get good practice, good average practice throughout the country. That's what you're trying to achieve, so that all surgeons are able to do a certain quality of practice. Okay, so once all that data is entered, then you get feedback every year. Okay, that is your own how many patients you did, were there any failures. So for example, for joint replacements, for the last 10 years, all the failures that you've had can be recorded. The other thing is patient populations are mobile nowadays. You can see that person who studied in somewhere in South India might get a job in Delhi or Bombay or something like that. How do you track such a patient? So you do have now things like your Aadhaar card, you got a number. So if such things are entered into a registry, some sort of number, in the UK, we have got a thing called an NHS number where every patient has got a number which is specific for that person. So if I now go from here to another place and have a revision in another city, the data can automatically be inputted to the registry. So they have a complete control and they know exactly, even though the population is migratory, that revision has been done. Now, data inputting as the registry becomes more and more mature, like Swedish registries, the Scandinavian registry, etc. These are almost have got a 90% input from patients. And that's a very high, if you look at any study, to get to 90% of the entire population onto that database is not easy. It takes many, many years to do that. And that is because of the Swedish system. It's all, the government pays for your healthcare. You get a unique number. You also have a database which records everything. So they're able to then come up with very meaningful statistics. But their population is so small. As you were saying, the population of India is sort of over 1 billion. So, how are you going to produce a registry like that? So that produces operational and technical issues, but it is possible. Maybe you can have a registry for a city. You may find it hard to get a national registry because of the very high volume that will entail. But and then how do you get private providers to contribute to that registry? How do you get government hospitals might contribute, because that might become compulsory or something like that. The government can push that down on doctors. But how do you get somebody who's a private practitioner to contribute to the registry? So it's all, unless you have some kind of rules, you find it difficult.
Dr. Sinha, do you want to add something?
Yeah, government is trying to use Aadhaar card for data generation. But again, you see, it runs into problems. People say it's a privacy issue. Some institutions are not willing to contribute. So it's a complex issue. But at our center, we maintain data. Whatever Dr. Menon was saying, we maintain the data in similar way. But it's for one center. So that cannot be called a registry.
Yeah. So if I might just add, I would say that's a very important thing. One of the important issues is patient confidentiality. So all the patients whose names are entered into the registry have to sign a consent. So if a person doesn't sign a consent, then you can't really use that data. That is in the UK. That's they're very clear about that. But having said that, most patients are not averse to doing this because, if you tell it the correct way, so that this is going to be looking at, implants that fail, operations that fail, some of the patients might be happy with that.
Let's have some questions.
Did you ask me?
Yeah.
Thank you. Thank you, Mr. Menon. That was a very nice presentation. Thanks a lot. I just have a few questions, actually. Are there any numbers on all inside ACL reconstruction in the registry?
Yes, if you need to look at the UK registry, it is showing a slight increase in the all inside technique in the UK. I don't know the exact figures, but if you look at the UK registry, the recent trends over the past 3 or 4 years show that there is a slight increase in the use of all inside technique. And that is certainly there in the UK registry.
As you said, it will depend on the instrument we use for recording outcomes, isn't it?
Yes.
Based on this ceiling effect and the floor effect of the instrument, the tool we use. Coups may not be sensitive enough to pick up everything. And also, there are a few aspects in ACL reconstruction we want to look at, but is the data entered for these, for example, augments, ACL augments, and preservation of stump? So when you are filling up data for the registry, do you fill up all these things? Do you upload X-rays?
Well, I think we don't upload X-rays and things like that, but having said that, the data, for example, whether you've used any augmentation procedure, that is uploaded. Whether I don't think stump preservation is particularly, no, I don't think that is uploaded. But basically, once registries can change with time, you see. So they might say initially you start with a particular set of factors that you want to put into the data. After that, a few years later, they might look at something else. They might add on more things. So as data, the registries mature, the data set can change. Now, for example, as I mentioned to you, many registries do not record conservatively managed ACL ruptures. Okay, so these are only those that undergo operation. So we don't have a control. How does, generally Swedish and Scandinavian registries suggest that those who do not have an ACL reconstruction don't have as good outcome scores as those who undergo an ACL reconstruction in those who have significant instability. Certainly that is known. But we do not know in somebody who's got lesser degrees of instability, how does conservative treatment fare long-term, etc. So that is one thing that this data now registries are tending to add. So that can change, registries can change. Likewise, the use of rehab techniques post-surgery. Now, you know that critical phase where the graft is getting incorporated into the bone is the first few weeks. And if you certain rehabilitative physiotherapeutic techniques may have an adverse effect on incorporation of the graft. And that is something else that some of the studies the registries are now looking at inputting such data. So you don't need to have everything right in the beginning. It might be that you have to change the data that you collect with time. And that is still acceptable. But having said that, obviously, if you collect more data in the beginning, then you get a longer duration with that data included. So that will have more meaningful results.
Would you say this is something like a departmental audit done at a national scale?
Yes, it is. It is. In fact, every department has got other audits. For example, for surgeons, they have colorectal audits. Where they look at outcomes following colorectal surgery. Cardiac has got the maximum. Cardiac is the people who can be in maximum trouble because their outcomes are very clear: death and versus living. So there's no sort of something in between. So if you do a cardiac operation, particularly pediatric cardiac surgery, and there's a higher death rate. Now you might have heard of the Bristol problem, which was there in Bristol, and recently there was a problem in Leeds as well. So if the government suddenly says that, okay, your death rate following pediatric cardiac surgery is 1.5 times the rest of the country, then immediately questions are asked, and you're asked to temporarily shut down your unit, and until those questions are looked at, what is going wrong in that unit. So it is a database which is different for different different specialties as well. And I think it should be used more as a way of improving practice rather than punishing people. That's what I think. Punishing. Yeah, it is important. That is important. Otherwise, people, they stop sort of contributing to it.
A question for both yourself and Dr. Sinha. Has registry data changed your practice in any way? And what aspects of your practice did it influence?
Right. I think certainly for me, I did do something which was a bit adventurous, which was to go on to the all inside technique, which is not normally me. I used to use the transtibial technique in the beginning. That was in my first few years, I used transtibial technique. But then when I attended lectures and then when I saw data on the transtibial technique, more to do with outcomes, not to do with not patient reported outcomes, not to do with registry data in particular. But when I looked at that, I thought it is better to go for a medial portal drilling. So that has changed. And then some of that data was initially sort of supported by registry data, and seeing other surgeons also moving to that technique. So that changed my way of portal drilling, which I think, for a person who's well into practice, to change techniques becomes more difficult. What you're trained to do, you are able to do more easily. So that is the advantage of going to different centers, learning different techniques from different surgeons, and that helps you to be conversant with more than one technique. So that one aspect changed. But now when I'm looking at the data, I've got to see now next that when I'm doing transporter drilling, having said that, I've not had any major issues with graft rupture. So I think the few graft ruptures that I've had, I can say confidently, are those where I personally feel that the portals were not drilled. The tunnels were not drilled in the correct place. And I think that does happen in every surgeon has a few cases like that where you'll find that your tunnels were suboptimal. And I think I cannot blame the actual technique on that. It's my own technical error. So that is something I have to understand. So what I tend to do is I believe that your practice is evolutionary. You don't suddenly change everything dramatically, otherwise you will be in problem. You will have a learning curve for that. So what you try and do is try and change your practice a little bit. So another thing that I looked at was when you have a graft which is of slightly narrower diameter, I use fiber tape, for example. That is something which I've used for some time. I've not had problems with it. And I find that there are some other surgeons who do that as well. So I'm not an outlier in that respect. So that is another technique that has changed by, again, looking at some of the data from registry. And of course, I also then compare with other surgeons. When I attend meetings or when I meet people, I then ask them to see if they also do this kind of thing. So it's not just purely registry data, but it's also with by talking to other surgeons.
Dr. Sinha?
Yeah, we also graduated from transtibial to transportal and outside in technique. And fixation methods also, we moved from aperture fixation on the femur to cortical fixation using adjustable loops and fixed loops on the femoral side, and aperture fixation on the tibial side. Yeah, that's from the registry. And
registry is basically something like a prospective observational cohort, isn't it? So if we have to generalize the results, we need to have there should be some minimum number of patients data available to generalize to the population. So if we have to start a study in India, what do you think is the number we should have to start digging into the data of the registry?
As Dr. Menon has suggested, it's always good if it's a government agency setting up the registry rather than any body which is a non-government body, to make it more compliant.
Okay.
And registry is important because if you learn from your own mistakes, it takes a long time to learn things. And if you learn from others, like looking at the registry, cumulative outcome of different people, then you learn at faster pace.
If I might add, I would say that you were asking the numbers that you want. So one of the things also is this, that the databases now that are there in the Swedish registry, if you combine all these registries together, you're getting something like 140,000 patients, 150,000 patients. Now, this is not a small number. And I don't think any individual hospital can get such a large number of primary ACL reconstructions. To get something in the figure of, in the rate of. So of course, you can't compare all the data between registries, but in individual registries, this data is approaching somewhere between 40 and 50,000 patients. And of course, the numbers that you need depends on the question you're trying to answer. So you would probably look at talking to a statistician, trying to generate, what are the what do you say, the p values that you want, the power of the study, etc. How do you rule out an alpha and a beta error? And you then get a figure. You might get a figure of, if it's a simple, straightforward thing without much confounding factors, something like 100 in each group may be good enough. But if it's something where there are multiple confounding factors, then you're looking at a multi-center study with maybe 4,000 or 5,000 patients. So that obviously takes many more years.
Yeah, so the results of the registry data from other countries may not be directly applicable to Indian population because of the demographics of the Indian population, the height, the weight, BMIs, and the activities that we do here. So that's what you mean. Are you able to pull up region-wise data from the registry? For example, in the Kettering region, you want to see the results. Are you able to look at that?
I wouldn't be able to do it personally, but I can see, because I'm the lead for the registry in our hospital, I can see our own unit, how we are doing. But there are regional advisors in each region, and they will have access to regional data. Likewise, if you look at the Swedish registry, they are very comprehensive. They go hospital by hospital. So you read the latest report in 2018 from the Swedish registry. It looks at the total number of cases done in every single hospital in Sweden. So they've subdivided it like that. And they therefore have that individual data for each hospital.
Okay. Okay. Thank you very much. It was very informative. Thanks a lot.
I think the data that is entered in each country is quite different with respect to the organization also. It's not only about the data, it's also about the organization, whether it is just entered as a whole country or by hospital wise or region wise. I think
hospitals are involved. Most of the hospitals are involved. In India, the practice is slightly different compared to the European and American practice.
Yeah, the practicing environment, the type of, and the amount of access to technical data entry is also, I mean, it's just not uniform all over India.
And do you think the allograft and autograft study may have been prompted by the registry data?
Yes, if you want, I can just share with you a little, let me see if I can get this up on the screen. 1 minute. 1 second, hold on.
Another thing is, as we evolve, we get new data from the, for management. Is there a facility for, accommodating these new fields into the registry data as we go along?
Yes, you can do that. But having said that, if you do that, then that particular, it becomes a staggered entry point. So you're putting in a new data at a staggered entry point, and the data from that point onwards will be what counts as far as that particular factor is concerned. So I will just show you, if I can, I'll try and share this KP registry, some details with you. Let me just see if I can do this. So I'll just share my screen. Is that okay? Let me see.
Yes.
So can you see my screen now, or?
Not yet.
Not yet. Okay, hold on.
Yes.
Okay, now you see this data here. Okay, this is from the Kaiser Permanente registry. Now, this is a very interesting graph. Where are we? Hold on. Yeah, this graph. Now, can everybody, you can see this graph here? Now you look at as you find this allograft, the probability of revision, if you're a young person, the probability of revision with allograft is exceedingly high. Okay, it's almost, if you look at, so if hazard ratios is looked at every point during this curve, and you can see that this risk of failure and revision is much higher at every point along this graph. When it comes here, it's sort of all three lines are roughly meeting. So this is allograft, hamstring autograft, and bone patellar tendon bone. So as these are all converging in this area, now if you use an allograft in somebody who's 41 years of age, around that sort of age, then your revision rate is not likely to be very much worse than somebody who receives a hamstring graft and a patellar tendon graft, okay, at this age. But if you try and use an allograft in everybody, then you will find that you'll have a very high number. For example, Dr. Sinha might be dealing with patients who are sort of this age and below, say below the age of 25, if you're dealing with athletes. Now, if you put allografts in all of these people, your revision rate will be very high. So this data it is possible from registry data to get these kind of graphs or these kind of curves, which then can give you what is called as, you can get a risk score. So if you see here, this is a presentation by another gentleman from the US registry. This is available on the internet. And you can see here that you can get a risk. So you put your age, you put your height, weight, injury, and probability of survival every year. It gives you a sort of a survival analysis. So if you're something like 16 years of age and you use, and it depends on the revision risk you're trying to calculate. At year 4, that is your revision risk. Okay, so only it's something like 16%. With each of these grafts, you can see that's allograft, autograft is better. You can see it's about 93% survive, bone patellar tendon, bone 88 hamstring, whereas the allografts don't have as good a result. Now, if you take the same thing for a 40-year-old person, at year 4, roughly all of them survive. So that is why I told you it is important for you to understand the population that you're dealing with. And therefore, the technique that you employ can differ for different populations. And this is possible purely because, these registry people have looked at the data, worked it out, but this is after many, many years. So this registry was established somewhere in 2005. So we've got 15 years of data, which goes to more than 50,000 patients. So they are then able to, the confidence intervals become much more narrow, and therefore the data becomes much more strong. So that was what I was wanting to share. So I will just unshare now 1 minute.
I think the more and more we delve into it, it's getting more and more interesting and puzzling.
Yes. So it is important to understand, I think, the patient population you're dealing with. You also got to understand that you can't extrapolate everything to your patient population, but you can obviously, one of the other ways is you look at data, discuss it, and discuss with other surgeons. And when you're introducing a new technique, you don't change everything. You just change one small aspect and see what your results are. By changing that one small aspect, if your results are not as good, then you've probably done the wrong thing. And of course, you need enough surgeons contributing to that. As an individual, it will take you many, many years to figure it out because the volume that you do is not that high as individual surgeons.
Okay, I think that was a very, very interesting session today that we had, and possibly that's going to give a very, obviously it's going to give a very clear outline of what registry data is and what you can make out of registry data, and possibly it's going to serve as a stimulus for some research works for the younger people respect to the various registry data and take the research forward in the right way, not in the take forward in the logical path rather than possibly, as you suggested, comparing, which is possibly not logical. Okay. Thank you very much, Mr. Menon. It was a very interesting and useful session. And thank you very much, Dr. Sinha. Thank you for joining us and sharing your knowledge. I hope to see you all again sometime soon later. Thank you very much, Dr. Srinivas.
Thank you.
Thank you, Mr. Menon. Thank you, Dr. Sinha.
Bye-bye.
Bye.
See you. Take care.